In this part of the four-part esophageal trilogy, I'm going to be talking about more focal esophageal distension, or segmental dilatation of the esophagus. And just like it sounds like, that's a distension of only one part or one region of the esophagus, and it's going to be caused by anything that may prevent flow through some part of the esophagus. Occasionally, we'll see a segmental megaesophagus that's really just a dysfunction, so a true functional and not mechanical issue, but usually it is a mechanical problem. So the primary causes of segmental dilatation can be intraluminal things like a foreign object. It can be something extending from the wall, a mass, inflammation, stricture, or it can be even something outside the esophagus that compresses the esophagus, most commonly seen as vascular ring anomalies, but other intrathoracic masses can do that as well. Survey radiographs are still going to be your place to start because you will often see dilatation of the esophagus in these cases. We don't see it as commonly if the lesion is more cervical, just because the esophagus doesn't have as much room to distend. And even if you see segmental dilatation of the esophagus, you may not see the underlying cause. It depends what the actual cause is, and so contrast radiographs or fluoroscopy may still be useful. Just like you'd expect, the esophagus is going to be dilated just like a megaesophagus, except now it's only part of the esophagus rather than the entirety. And so the distension that we see is going to be cranial or orad to the lesion. That's where the gas or fluid or food or whatever is backing up on the mouth side of the lesion in question. Depending on how acute the presentation is, you may not see much or any dilation of the esophagus. There can be other signs, but it depends more on what the specific cause of the distension is. So there are four main causes of segmental dilatation that I'm going to talk about. Here they are. We're going to start with foreign bodies. It's probably the most common thing we see in veterinary medicine. There are a number of spots that we more frequently see foreign objects, although they can get lodged wherever. So cranial cervical region, right at the thoracic inlet, right at the level of the heart base, and then right at the level of the esophageal hiatus, so kind of at those kind of narrowing points of the esophagus. Common items, anything that a dog eats, or a cat, or a horse. Bones are common, fish hooks and needles, other metallic things that get kind of stuck, any sort of chew toys that patients may have. Obviously, when there is an esophageal foreign body, it's going to be causing some degree of obstruction, so that's a problem itself. But there's additional concerns that it could result in esophageal laceration and perforation. If it stays lodged in one place, it can cause pressure necrosis of the mucosa, which then may lead to stricture down the line. So there are other things we have to look for, or at least be aware of the possibility of. Because there's a risk of esophageal rupture, you have to be doubly on the lookout for secondary signs like mediastinal effusion, other mediastinal contents, pneumomediastinum, or gas in the fascial planes of the neck. So all those tissues around the esophagus where gas or fluid or food might leak. On survey radiographs, the esophagus, that distended segment of the esophagus, is variable in opacity. And the foreign object itself is going to be variable in opacity, just depending on what it's made of. So a soft tissue structure, soft tissue opacity foreign object may not be visible on survey radiographs because it may silhouette with the fluid in the esophagus that surrounds it. Maybe you get a hint that there's something there, you may not. Certainly if it's a mineral or metal foreign object, it's going to be a lot easier to see. If there's gas in the esophagus, you still have a good chance of seeing a soft tissue opacity object because that gas is more likely to highlight it nicely. If you see a foreign object on survey radiographs, you really don't need to go any further with your diagnostics. You can go deal with the object itself. You don't need to do fluoroscopy. You don't need to do an esophagram. So this is one that would be pretty straightforward. I see gas in the esophagus here. There's focal or segmental dilation of the esophagus, and then there's a metallic bottle cap lodged squarely in the esophagus. So that's a pretty straightforward diagnosis. We don't need to go any further. Sometimes things aren't quite as apparent. Again, I see esophageal distension with gas here in the cranial thoracic region, and then there's a soft tissue opacity structure, and it looks like the gas is kind of trying to sneak around it here. It's kind of sneaking around it there, but not very well. So This, again, is a soft tissue structure causing segmental dilation. And there's gas in the esophagus. You can see it kind of sneaking or trying to sneak around the soft tissue thing, and there's our structure. Again, we're not seeing all the margins of the structure, but we can see that cranial margin because of the gas in the esophagus. And so this was an intraluminal foreign object. Now, this isn't a 100% diagnosis on the basis of what we see here, because this could have been a mass growing into the lumen and causing similar signs. But if it's an acute onset problem, it's much more likely to be a foreign object. Either way, you need to go to endoscopy and get a look at this thing and take it out, or get a sample, either, depending on what you end up seeing down there. And this ended up being a rawhide chew. Horses can get esophageal foreign bodies. This horse has a mineral opacity structure immediately dorsal to the trachea, so it's in the plane of the esophagus. It looks an awful lot like a tooth, as it turns out. So this horse has an esophageal foreign object, specifically a tooth foreign object. There's no esophageal distension, and so it's less likely that this is a problem. And in fact, on subsequent radiographs, it was no longer present. So this horse had swallowed its own tooth, and we just coincidentally happened to catch it on this radiograph as it was being swallowed, as the tooth was passing downward. So remember that we always want to be a little concerned about foreign objects, but they don't have to cause clinical problems. When doing an esophagram, contrast medium will outline the foreign body very nicely, and so you'll see an intraluminal filling defect. So in other words, the contrast material should go all the way around it, or most of the way around it, and demonstrate that the object is truly within the lumen, not having a broad base coming off of the wall. And so that object may cause a complete obstruction, and in which case you may not get visualization of the caudal edge of the object, because the contrast medium is going to be stuck along the cranial edge. With a partial obstruction, the contrast medium can get all the way around, or at least most of the way around, and you can really see how big and extensive the object is. So here's a case of a dog who has an esophageal foreign object. We've given contrast medium. You can see there's this nice rectangular filling defect in the midst of the esophagus. The contrast medium is going all the way around it. So this is a partial obstruction. There's some other material further down. I'm not sure. There's maybe gas bubbles, but there's enough of them. I wonder if there's some kibble or other objects down there. And this was a rawhide foreign object that we use endoscopy to get out. So I alluded to masses as another cause of segmental dilatation of the esophagus, because they can look like foreign objects, and so now we need to talk about those at least a little bit. When I see a mass of the esophagus, I'm always concerned about neoplasia. If it's a mass that looks like it's extending from the esophageal wall, whether that's deeper in the wall or the mucosal part, I think about squamous cell carcinoma, so more mucosal, leiomyosarcoma, deeper muscles of the wall. You can also get osteosarcoma or fibrosarcoma in patients who have spirocercal lupi, so dogs who have spirocercal lupi granulomas that then undergo malignant transformation. If the mass looks like it's coming from outside the esophagus, then you have to think about what structures live near the esophagus. So there are various lymph nodes near the esophagus, so anything that metastasizes to lymph nodes could do this. Certainly histiocytic sarcoma and lymphoma are big ones that will cause gigantic lymph nodes or other mediastinal structures and could potentially compress the esophagus. Granuloma, depending on where one lives, spirocercal lupi is a parasite that will cause mural granulomas in the esophageal wall, and so that is another something to think about if you see an esophageal mass. Abscesses can happen, and that can be in the wall or can be just outside the wall if there's been a perforation of the esophagus secondary to a foreign object. And then a lesser common thing would be a paraesophageal hernia, so kind of extension of the stomach or protrusion of the stomach beside the esophagus, outside on the cranial edge of the diaphragm, can secondarily compress the esophagus. But again, that's pretty darn uncommon. On survey radiographs, same story as before. We're going to see dilation of the esophagus cranial to the lesion. Degree of dilation depends on how severe it is, how long it's been there. Usually we see a soft tissue opacity mass that is causing the obstruction. Depending on the size of the mass, we may or may not see it. It can have mineralization in it as well, so that may help us identify the mass. And like I said before, it can be tough to differentiate foreign bodies and masses, and then the fluid in the esophagus may silhouette with it either way. With an esophagram, we should be able to find a mural or mucosal filling defect if that mass is extending from the wall, or an extramural filling defect if the mass is outside the esophagus and compressing the esophagus. Here we have survey radiographs on a dog who has an esophageal mass, and the mass itself on these survey radiographs is not well delineated. I see a soft tissue opacity structure here in the region of the thoracic inlet, and I kind of see this band of gas sneaking around it. So there is evidence of something going on in here. It's not the most distended esophagus cranial to that, as it turns out, but there is definitely a structure there, whether it's a mass, whether it's a foreign object. As that gas kind of tracks around it, it does make me suspicious that it's coming from the esophagus, though. Ventrodorsal view, I've got some widening of the cranial mediastinum. The trachea is sneaking a little bit more to the right than normal, so suggests, again, there's a mediastinal mass here. Esophagus would fit, but it's certainly not specific for esophagus on the basis of that. When we do our contrast procedure, when we do an esophagram, now I see that there is contrast medium kind of sneaking around one edge of this mass, but you can see it's very ventrally displaced, this contrast edge, the lumen of the esophagus. I don't get any filling along the dorsal edge of the mass. On the VD view, there are edges of the mass that also don't have any filling, so it has more of a broad-based appearance because the contrast medium gets past the thing, but it can't go all the way around all the edges. It makes it seem like it's really not intraluminal. I have to be thinking of mural or mucosal at this point. The margins are a little more irregular probably, so I think mucosal is going to be higher than mural specifically. After sampling, this was neoplastic and was most compatible with carcinoma. Stricture can be secondary to a number of things, often secondary to foreign bodies or other trauma, and will cause a degree of obstruction of the esophagus and thus segmental dilatation of the esophagus. So again, trauma is the most common. Other causes of inflammation can do this. So a patient who's had esophagitis, maybe from gastroesophageal reflux, doxycycline can cause this in cats. And so you get secondary fibrosis, and it will stricture down and again cause narrowing of the lumen and at least some degree of obstruction. And you'll see the usual things on our radiographs. So on survey radiographs, again, you're going to see a focal dilatation of the esophagus cranial to the lesion. The stricture is a soft tissue opacity. It silhouettes with the wall. You're not likely to see that on survey radiographs. So here we really do need an esophagram or endoscopy to make our final diagnosis. And you're going to see focal narrowing of the esophageal lumen, and it's going to be a persistent mural or mucosal filling defect. So it's not just peristalsis. I'm not showing survey radiographs on this one because they weren't very helpful. So here we have our esophagram, and I can see that there's a nice bolus going down the esophagus that has traveled nearly to the stomach at this point, and there's a focal narrowing in the midst of that bolus. In real time, I can see that this narrowing was a single spot and the bolus had to sneak through it. If I got multiple images, I would be able to see that it was always in the same place, so it's not just a peristaltic wave. And additionally, normal peristalsis, remember back to part 1 of the lecture series, normal peristalsis causes narrowing at the most caudal aspect of a bolus and pushes it down. The peristalsis moves down the esophagus and moves the bolus down the esophagus. You're not going to have a random peristaltic wave in the middle of a bolus just triggering. So even if I saw this on a single image, I would say that's a stricture because I know the peristalsis is here. Esophageal peristalsis doesn't happen in the middle of things. This will be a little bit different when we talk about the small intestine, but with the esophagus, once I see this on a single image, I have my diagnosis of an esophageal stricture. I talked previously about a number of causes of extraesophageal compression. So any lesion outside the esophagus can do this. Congenital vascular ring anomalies are certainly the most common in our veterinary patients. We see them in young patients, and basically a narrow ring caused by this odd vasculature will entrap the esophagus, compress the esophagus, and result in regurgitation that usually gets diagnosed or at least noticed as the patient is weaned and goes from a 100% liquid diet to eating more solids that now can't pass through that markedly narrowed esophagus. Other mediastinal masses will do similar things. Usually those are in older patients. congenital lesions are young. Masses are often neoplastic, so usually older patients. Usually these are not as severely affected because a mass has to be gigantic before it compresses the esophagus enough to cause really narrowing of the lumen. There's enough room in the mediastinum for the esophagus to work with for a while. And so these signs are usually more mild, they're usually more progressive. Of the vascular ring anomalies, a persistent right aortic arch is the most common in dogs by far. There are other possibilities that I've listed here. I'm not going to talk about them in any real specific way, but they can occur as well. So here we go. We're going to talk specifically about our persistent right aortic arch, because again, that's our main source of extraesophageal compression in our patients. Embryology that you don't remember. Normally, the left fourth aortic arch turns into the aorta. The right fourth aortic arch becomes part of the right subclavian artery. With a persistent right aortic arch, that left arch actually disappears, and the right arch becomes the aorta. So the aorta kind of branches off the wrong side. It's still coming off the left side of the heart, but it's coming toward the right side of the dog, which it's not way to the right, so at least at face value it seems like maybe that wouldn't cause a big problem, but it does. So here we have a view from dorsal to ventral, so a top view of the heart, and the normal aorta kind of arches off toward the dog's left this way, and here you have the main pulmonary trunk, and between them is the ligamentum arteriosum. And remember, this ligamentum arteriosum was the ductus arteriosus in utero. And you can see, and again, in a normal dog, the esophagus is off to the side, no worries, no problems here. Again, notice this is a top-down view, so it's flipped relative to what we would see on a VD radiograph, just to throw that out there. Now, same view in a dog with a persistent right aortic arch. Now that arch is moving to the right. But in utero, it still needed a communication, a connection to the pulmonary trunk. And so you still had a ductus arteriosus, or now ligamentum arteriosum, that had to span this much broader area. And now the esophagus finds itself caught in the middle, where before it was beside both of the big vessels. Now it's between them, and that ligamentum arteriosum is going over the top. So what's that going to do? It's going to compress the esophagus like that, and that's going to lead to backing up of anything that this dog tries to eat, and ultimately formation of focal esophageal dilation or an esophageal diverticulum ultimately. So your survey radiographic signs are going to be very similar to all the other things in this part of the lecture. Focal dilatation of the esophagus that's cranial to the lesion. A key finding in a persistent right aortic arch specifically is that the trachea gets displaced to the left. So remember that aortic arch, rather than going to the left, is now going to the right, where the trachea usually hangs out just a bit slightly to the right. So it actually pushes the trachea to the left, and that's actually a pretty specific finding. We don't see that really in many other diseases other than this one. So that's actually a key bonus finding that really will help you make this diagnosis, because otherwise on survey radiographs you can't see the persistent right aortic arch. You're just finding the secondary changes to the thorax. So here's a dog with, guess what, a PRAA. We see focal esophageal dilatation, a little gas-filled esophagus here, and even further forward. Nothing caudally, though. The caudal part of the intrathoracic esophagus looks just fine. So already I'm thinking that the lesion is probably at this level right here, at the level of the heart base, which is the right spot for a persistent right aortic arch. It's also a young dog. He's got open physes, so we're in the right age frame for diagnosing a persistent right aortic arch. So there you go. There's our esophagus. Again, the dilation ends right there. The trachea is ventrally displaced just a little bit, not tons. When I go to the VD view, now I see that there's a very wide mediastinum, which is not surprising with esophageal dilation, but there we go for that. There's our key. Notice that normally the trachea should drop all the way down, nice straight line, but here we have a little bit of a bumping to the left. Again, remember, this view is flipped relative to our dorsal view of the heart, so now our normal aorta would come out on this side, on the patient's left. Now it's going to be here on the right side. So it's going to push the esophagus push the trachea focally to the left. Here we see it again without the overlay. There's this little subtle shift. That is enough. We don't see that with really any other disease process, especially in light of esophageal dilation, focal esophageal dilatation. So here, everything put together, we have a really strong evidence that this dog has a persistent right aortic arch. When we do an esophagram, this is a fluoroscopic image, so air is white, contrast medium is black. Again, we see that there's focal distension of the esophagus. It ends really suddenly at the level of the heart base. So vascular ring anomaly, stricture are differentials that you would have on your list. Again, everything pretty much fits in this case for a PRAA specifically. So that wraps up focal distension of the esophagus, and we will finish up this series with a few brief comments on other esophageal diseases.